National Osteoporosis Foundation in 2021. And you can see in the Netherlands, 21% of women and 6% of men aged 50 years and older were estimated to have osteoporosis in 2019. And the number of new fertility fracture in the Netherlands is estimated as 99,600, corresponding to 273 fractures per day and 11 fractures per hour. And this number is further projected to increase by 37% over the 50-year interval in the future. And the healthcare cost of osteoporotic fractures accounted for 1.8% of the total healthcare spending in the Netherlands. So over the last 3 decades, various therapies with different mechanisms were available for osteoporosis. And in summary, there are 2 types of therapies for osteoporosis. The first type is anti-resorptive drugs, so which usually modulate the inhibiting of bone resorption. And the most common one is bisphosphonates, which is recommended as the first-line therapy in the guideline of most countries. And the second type is anabolic therapy, and which is characterized by an increase in bone formation. And the common drugs are teriparatide, abaloparatide, and romosozumab. And the last one is approved by EMA in 2020. And in recent years, the sequential therapy has been endorsed in a lot of clinical practice in osteoporosis management. So, and several studies reported that the greatest gains in the bone mass can be achieved with the initial use of anabolic therapy, followed by an anti-resorptive drug. So, as I mentioned, there are a lot of drugs already.
Sorry for interrupting you, Dr. Lee. Could you please unmute your Zoom, please? Thank you. Yeah.
Can you hear me now?
Yes.
Okay. I will continue. So, we found that a lot of osteoporotic patients are not diagnosed and untreated, and the treatment gap in the European population was estimated to vary from 25 to 95%. And I found an Asian study which reported an average treatment gap of 37% among 6 countries. In addition, we found that for patients who initiate the treatment, we found most people do not take the medication as prescribed. And so we call it poor medication adherence. Here is a Dutch study which showed that in Dutch patients with a recent fracture aged 50 years and older, the persistence rate of bisphosphonates was reducing over the 5 years. So consequently, the poor medication adherence would result in increased fracture risk as well as societal economic burden. And to optimize osteoporosis management and improve medication adherence, it's very important to understand the underlying reasons of no adherence. So we also call it determinants of no adherence. So we need to understand why these patients are not willing to adhere to their therapy or cannot adhere to the therapy. And our team has published a book chapter which summarized the determinants into 4 groups. So the first one is patient-related factors such as older age, misconceptions about osteoporosis, and low-risk perception. And so maybe a lot of people think when they get older, the osteoporosis is a normal thing, and there's no need to get any treatment. And the second factor is therapy-related factors such as higher dose frequency, convenience of administration, and side effects. So, for example, some osteoporotic medications should be taken daily, and for some treatment, patients need to have subcutaneous injection, and also a lot of people think, oh, it's very annoying to have gastrointestinal side effects when they take this kind of medication. And the third factor is the system-based factor, including the care under different medical specialties and the lack of patient education, because patients don't have enough health literacy to understand what is osteoporosis and what's the consequence of osteoporosis and what's their current and what's their fracture risk in the future. And the last factor is the socio-economic related factors. So, like the lack of medical insurance coverage. So maybe a lot of patients are not willing to pay a lot of out-of-pocket cost for their medication. So, in response to the care gap in osteoporosis management and to improve patient health outcomes, it's very important to have some strategies, or we also call it interventions. The interprofessional education is more and more popular in healthcare. Therefore, in the second part, I will give you some examples of the application of interprofessional education in the field of osteoporosis. So my first example goes to the setup and the implementation of the post-fracture care coordination program, such as the fracture liaison service. So this program is initiated by the International Osteoporosis Foundation in the year of 2012. And recently we found that more than 1,000 fracture liaison surveys were implemented in 6 countries. However, if you look at this map, you can see that no fracture liaison service is implemented in Indonesia. So you might have a question, what is the fracture liaison service and why it is very important for the country or for the clinical practice? And the fracture liaison service is a coordinator-based care for people aged 50 years and older with a recent fracture, and the aim is to reduce the risk of their future fractures. So in an FLS, a team of healthcare professionals, and it can be the healthcare professional from the primary care, such as the GP, and also include the physicians from the secondary care, such as orthopedic surgeons, radiologists, physiotherapists, and also as well as the pharmacist. They work together under the coordination of the FLS coordinator to ensure that all fracture patients I identified, diagnosed, and treated for osteoporosis. And the patient will also receive a proper long-term monitoring and care in this program. And but how about the clinical efficacy of the fracture service. So our team has conducted a systematic review and meta-analysis to investigate the effectiveness of fracture service on subsequent fracture and mortality rate by comparing fracture service versus no fracture service. And we found that the fracture service was associated with a significant 30% lower probability of subsequent fracture and 35% lower probability of mortality. So you can see that the implementation of fracture service, which can be regarded as a kind of interprofessional education or the collaboration between different healthcare professionals, could definitely improve the patient's health outcome. And my second example goes to the application of effective fracture risk communication strategies. So in the real world setting, normally we found that the conversation between the healthcare professionals and the patient, or the written letter from the healthcare professionals for the patient, is usually poorly expressed and cannot fully understood by the patient, given their limited health literacy. Therefore, our team found several strategies which are quite helpful to help patients to understand their fracture risk and make them adhere to their treatment and improve their health outcome eventually. Specifically, we think the healthcare professionals should use simplified language by avoiding use of clinical and statistical jargons when they communicate with the patients. And also some numerical data, such as the frequencies per percentage and properties, should be adapted to the literacy level of the patient. And also some UZ pictures, or we also call it visual aids, would also be very helpful for the patient. For example, if you just tell the patient your risk of breaking a bone in your spine or forearm, shoulder, or hip in the next 10 years is about 21%. So the patient don't have a very clear concept. What does that mean about 21%? And then you could use a picture like the face array, and you can say that there are 21 red faces. So which means that this patient will break a bone in the next 10 years, and you are one of these 21 patients, and people just like you that do break a bone in the next 10 years. But how large is the 21%? And then you can use like the bar graph or the stoplight color system, and you use different colors which represents different levels of risk. And you could say that your fracture risk is in the red region. So it means that you have very high risk to break your bone in the future. So it also means you really need to take some action to prevent your future fracture and reduce your fracture risk. And also we found that take into account patient's preference into the medical decision making, namely the shared decision making would also be very helpful. So, for example, maybe some patients prefer to take tablets instead of injection. So you really need to take into account what does this person want for their medical decision. And to test the effectiveness of the strategies that are mentioned in the last slides, our team has conducted a pre-post study. And in our study, we have an intervention called multi-component adherence intervention. and which include patient decision aid and motivational interviewing. So in this table, you can see which is the content of the decision aids, which includes 8 pages of educational information for the patient, including their fracture risk, depicted by the pictures as I mentioned before, and also their personalized lifestyle and the medical suggestions I also presented in this photo. And then our study compared the multi-component adherence intervention to the Eurocare to capture the effectiveness of the strategy that we use. And we found that patient in the intervention group has higher IT osteoporosis medication adherence and the persistence rate, and also the treatment initiation rate is also higher in this group. I see some chats. Is that okay, Vavan? Can you hear me?
Yes, perhaps we still have 1 minute left to wrap up your presentation.
Okay. And we also conducted an economic evaluation to evaluate the cost effectiveness of our intervention. And a favorable result is also indicated. And this information is quite important to prioritize the intervention and to give some suggestions during the decision making. And the third part of my presentation goes to the application of biochemical markers for medication adherence in the field of osteoporosis. And as I mentioned before, the poor medication adherence to osteoporotic medication is well recognized, and this problem is significantly influenced the treatment efficacy and the cost effectiveness of the drug therapy. Therefore, identifying reliable methods to monitor medication adherence is very important to tackle this problem. Traditionally, we use the DXA-based bone mineral density measurement to monitor medication adherence for the patient. However, clinically meaningful change in the bone mineral density takes at least 2 years after the treatment initiation. But we know that normally the no adherence most frequently occurs shortly after the treatment initiation. Therefore, a more sensitive measure demonstrating earlier response would be favorable. That's why the bone total marker is increasingly used to monitor the treatment response and medication adherence, giving a meaningful change can be captured within 3 months after the treatment. So specifically from this picture, you can see at baseline, we will have a measurement of the bone total marker at baseline, and then this patient will initiate their treatment, and 3 months after their treatment, and we will take another measurement of their bone total marker. So if the bone total marker decrease is over the least significant change, so it means the treatment is already effective and these patients can continue their treatment. Otherwise, it means the ineffectiveness of the current therapy. So the clinicians should reassess the treatment strategies for this patient and also assess the reasons for the ineffectiveness. Maybe it's because of the poor medication adherence or some other issues. And although the clinical application of a bone total marker is increasing, we found the real-world evidence regarding the clinical and economic impact of the bone tumor marker monitoring on medication adherence is quite limited. And one study revealed that the positive feedback using bone tumor marker data would lead to higher medication persistence. And another UK study indicated that the patients in the bone tumor marker monitor group have higher treatment initiation rates and more likely to switch to other therapies and have fewer new factors compared to the unmonitored patients and has the potential to be cost effective. And these findings I confirmed in our study. We also collaborate with a team in Denmark and we use a bone tumor marker to monitor the treatment to monitor the treatment for patients. And in this case, we use the bisphosphonate for these patients, and we also found that the patient have higher medication adherence, and also the higher proportion of patients are willing to switch to other treatments such as the denosumab or the teriparatide. And also we found the bone tumor marker monitoring is cost effective in the Danish context. Given our study is not published yet, so I didn't show any data here. And there are some implementations of using bone tumor markers in the field of osteoporosis. So first of all, we think it can be a very effective tool for the clinicians to timely identify the treatment ineffectiveness, to explore the potential reasons, and to adjust strategies to ensure that the patient receive optimal treatment and avoid unnecessary personal healthcare expenses. And the second one, so it can also be used as a effective feedback tool to facilitate the communication between clinicians and the patients. So the clinician could help the patient to understand how the medication work in their body and why it shows the medication is effective, and to give more confidence for this patient to continue their treatment. But we would say the bone tumor markers are not the sole determinants of treatment adherence, and the treatment decisions should be made in conjunction with other clinical indicators to optimize treatment outcomes. And the last part of my presentation goes to the discussion and conclusion. So first of all, the Fracture Lean service represents an interdisciplinary collaboration program which connects different physicians and facilitates communication between them and the patient for secondary fracture prevention. And secondly, the interprofessional education and effective communication are quite helpful for patients to understand their fracture risk, improve medication adherence, and optimize osteoporosis management. And lastly, bone tumor marker monitoring as an innovative way for osteoporotic medication management could lead to clinical and economic benefits in the long term. Thank you so much for your attention.
Thank you, Dr. Nananli, for such an insightful and thought-provoking lecture related to osteoporosis treatment management from various perspectives, particularly based on the evidence-based research, what you have done for the last over 5 years, perhaps, and also you are working on this issue as well for your postdoctoral research, right? So there's a very insightful information, Dr. Lee, and unfortunately, because of the time limitations, we only receive one question from the participants. If you wish to respond to these questions, it would be very great, and we would be very happy. So the questions with regard to the barriers to its implementation. So could you elaborate a little bit what kind of obstacle or challenges that may faced by healthcare providers or healthcare professionals in response to improving the quality of osteoporosis treatment? I mean, like in any settings, in the hospital settings, in the middle income country settings, or high income country or developed country settings. So could you elaborate those issue? Thank you.
Yeah, okay. Thank you so much for this question. I think the most common reason is the patient and as well as the healthcare professionals have low risk perception for osteoporosis and the related osteoporotic factors in the future for these patients because from a lot of official documents or also from the social media, and I think a lot of people are influenced that the some other disease like cancers or vascular disease are the most severe disease for patients. So which will give an impression for these patients that the osteoporosis is not needed to get treated. But actually, as I mentioned, it will cause fertility fractures, and also the economic cost is very huge. And for the healthcare professionals, I think especially in the developed countries, as I mentioned, the fracturing service is already available for almost 15 years, but a lot of countries don't have fracturing service, and the one reason is um, they don't know how to set up and implement the fracturing service in their clinical centers, and also as I mentioned, they have a very low risk perception to have this kind of program in their service or in their care. So I suggest that given there's no fracturing service in Indonesia currently, I suggest that maybe the clinicians or the administrators in the hospital could first look at the website of International Osteoporosis Foundation, and there are a lot of information about how to set up the fracturing service and how to improve patient education and how to improve the quality of their service for these patients. And also it includes a lot of best practice framework and the key performance indicators to assist the clinical practice to set up and implement the fracturing service for the secondary fracture prevention. Thank you. I don't know whether I answered this question.
Yes, it's a very comprehensive answer and response. Dr. Lee, thank you so much for the answer. And actually, we have like 5 to 7 or to 10 questions, but because of the time, perhaps we will list the questions and then we'll send it to you if you don't mind to respond the questions on email. So we will contact you after these sessions. So yeah.
Yeah, in the first slide of my presentation, I showed my email address, and if you have further questions, you can definitely send me an email, and we can have further communication.
Yeah, thank you so much. So for the appreciations, our committee already provides you certificate of appreciations online. We will send to you after this, Dr. Lee.
Oh, wow, that's so great. Thank you.
Thank you so much. Thank you so much. We hope that you can join us for the next events on site, yeah, in person in Indonesia, and we look forward to it.
Yeah. Okay. Thank you.
Thank you once
Thank
again
you.
to Dr. Lee and to everyone here who is attending online and also on site, the Swiss Bell Hotel Jambi. So with that, I formally close this session. Have a wonderful afternoon and also have a wonderful morning in Masri for Dr. Lee. And I look forward to see you in the upcoming sessions. Thank you so much, Dr. Lee. I wish you a pleasure day. Thank you.
Thank you. Bye bye. Enjoy the
Bye.
conference.